Mitchell.
Yes.
Hi, Mitchell. Oh, sake. Hi, Mitchell. I'm Louise. I'm going to be your radiographer today. Why don't you come into my room? Okay. So, Mitchell, I need to ask you a few questions before we start.
All right.
Okay. Your full name, including the middle initial,
Mitchell H. Foley,
and your date of birth.
12/25/92.
Okay, good. Have you did you remove everything from underneath your Johnny?
Yes.
Okay, no buttons, no shirts. You can have your shorts on, your undershorts on are fine. They have, metal on them, do they?
No.
Okay. So you've done that. Were you given directions to prepare for this by your doctor?
Yes.
Yes, you were. Okay. And so I'm going to ask you a few questions about that, okay?
All right.
Have you had anything to eat or drink after midnight last night?
No.
Have you had any gum this morning, chewed any gum?
No.
Smoked any cigarettes?
No.
Taken any medication?
No.
And you haven't had anything to eat or drink
No.
since last night? Okay, good. So have you had this before?
No.
Okay. You've never had barium before. I'm going to explain a little bit what we're going to do.
No.
So you're having problems with your stomach?
Yeah.
Yeah, okay. So this is what the study is going to do. It's going to let us look at your esophagus, which is sort of the swallowing tube connected to your mouth, and your stomach as well, and a little bit of your small intestine. And we're going to do this by giving you a substance called barium. It's kind of thick, a little bit chalky, looks like milk of magnesia. You'll be drinking that according to the way the radiologist directs you, when to drink it and when to swallow. You'll also be given these crystals, which are going to be thrown in the back of your throat with water. It's going to create gas in your stomach, and it's important that you don't burp, okay? Because we want that gas to stay in your stomach, okay? Do you have any questions?
No.
No? Okay. After the radiologist is done, I'm going to be taking some images of your stomach as well. So you'll probably be in here about 20, 25 minutes.
All right.
Okay? So we've done all that. I'm going to have you get up onto the table.
All right. Should I have my shoes or?
You don't have to. I'm going to have you lie on your stomach. I want you guys to remember to be helping your patients on and off. You put your arms up in the suffocate. Okay, I need you to slide over to your right side just a little bit. Whoop. Okay.
Yeah, I'm fine enough.
Okay. Looks like I have to push your feet just a little bit. And I do need you to lie flat, however. Okay, put both hands on either side, that's fine. As long as your belly is flat. Good. Straighten you out a little bit. Let's do this first one with you just lying on your stomach. And we're going to be rolling up a little bit from side to side. Okay. All right, I'm going to move you a little bit with this table. I'm going to need to poke you on your back and on your side, okay?
All
All right. So I would say Mitchell is fairly average, a little bit hypersthenic, but not really that body shape. He's tall. So finding the curve of the rib, I can show you that better when I do the AP. But one thing it says, another direction, is take the bottom lateral aspect of the ribs and come up about 2 inches, 2.5 inches, and that's going to put you right about the curve of the rib. So the curve of the rib, if the patient's AP, is you go from the xiphoid to the lateral aspect of the patient and bisect that point. So you kind of, you know how your ribs have kind of take a corner turn, sort of? Some people more than others, but that's kind of where you want to be. Okay? You know what, Mitch, I'm going to have you slide over a little, just a tad towards me. That's a half a tad. Okay, good. All right, good. So the second place in the PA, which is hard to find, the curve of the rib, is I can palpate the top of his crest, and I really only want, you know, maybe 3 inches at the bottom of my film. Especially I have a 14-17 for this one. The field size is going to be 14-17, okay, for the PA. It's a full PA. And I might just go a little bit, oh, I'm sorry, off to the left slightly. So I want to be mid-sag or slightly off to the left. The more hypostenic or astenic stomach, most of the stomach's going to be on this side. But remember, I want the cell to be right under that stomach, full of area, so I get good penetration. And I need a marker.
So you don't
Squeeze
center
me.
out the crest.
Not for this one. Nope. Not for the stomach. You want to be higher than that. And you're going to need to go into the chest a little bit. You have to get the diaphragm on there. So
But you said the crest is pretty much the bottom of the film.
a couple inches of the crest into the bottom of the film, from the bottom of the film. So my left marker here, since I'm not really collimating. Okay, Mitchell? Okay, good. All right. Mitchell, I want you to take in a deep breath, blow it out, and hold it out. Don't breathe, and click. Now, a couple things. Be careful about this pillow. You don't want them to pull it down into their upper abdomen. Shielding is very tricky. Males a little bit easier. I just need to shield them where it's necessary. For females, for this one, I can't really fully shield the pelvis because we're going to need a little bit of that in there. So you can go about half of the pelvis.
For a woman, you said?
For the woman, yeah. The other thing you can do is just double check your film, and at least if you have this at the bottom of your film, you don't want it into your field. That's the PA. Okay. Change my film. You're going to use a 14. Did I put that thing? Oh, I didn't check. The CR identifier needs to be down. Now, I'm going to do the RAO, so be very careful. You think RAO, you think right marker, but I'm still focused on the left side of the patient, so I actually have to make sure, I'm not going to put that on there, I have to make sure that I mark the side correctly. It's going to be his left side that I'm going to need to mark. And I'm going to use 11 by 14 for my collimation. So Mitchell, what I'd like you to do now is to put your right arm by your side, and I want you to roll up onto your right hip. Yep, good, okay. Bring this knee forward. So in an REO, they practically get right into position for you in terms of the obliquities, about 40, 45 degrees, and drop your hip down just a little. You want the entire torso in the same plane. So for instance, you don't want shoulder, can you relax this down? Just put your arm up that way. This down and this up, or vice versa. So go ahead and bring it back up, thank you. The wish here. Okay, so now I have an 11. I'm going to put my marker in the very low corner of this. 14, 17. So curve of the rib, and at the lower border of his ribs, I'm sorry, you take it, sorry. And I need to feel his xiphoid, and this is a hard position. I'll show you in the LPO, but I'm going to bisect this. Or I can just kind of feel his ribs. Feel where he curves. Secondly, I can look at my crest, and I only want maybe about an inch. It depends on his body habitus. So for the astenic patient or hypostenic, what might I want to do with this centering? This is average. Yeah, I might want to bump it a little bit low, but for the average person, I probably want maybe an inch and a half of crest on the bottom. I also need to see light field. So really, most radiographers are going to kind of place them according to those dimensions rather than curve of the rib. Not that you can't be in that area, but what Merrill's told us for the longitudinal centering is a vertebral column, I've got my finger on his spinous processes, lateral aspect of the patient's body, and I'm going to bisect. So for him, it works pretty good. I'm about in the middle for that. Perfect, Mitchell. But what I really want to look at is the light field on the table, okay? I need to give myself enough light so when he breathes, he's actually going to be doing expiration, so he's going to come out and then come back in, so that's not a big concern that he's going to move very much. So, looks good. Okay. Mitchell, taking a breath, blow it out, and hold it out, and click. You can breathe. That's the RAO, stomach. Any questions? Guys, I'm in awe, aren't you? Now, Mitchell, I'd like you to roll over onto your back. I'm watching you. No worries. Now, I need you to slide over towards me just a tad. That's a good tad. Okay, arms down. And, well, you're probably going to need to roll up away from me, all the way up. Okay, now come back down this. So when you do the LPOs, and it depends on the patient, if they're very lean, thin, small, they're not going to sink much into the cushion. But if they're heavier, larger, you want to roll them way up. Stick this underneath and have them come back down. And if they sink a little bit, you're still going to be at about 45. And if you're not, it's a lot easier to kind of bring them flatter if you have to. So this one goes by your side. This one is up by the pillow. Okay, so here's the curve of the rib if you want to palpate for it. Xiphoid, that's your xiphoid, right? You get a little t-shirt. Lateral aspect, okay, and then we're going to bisect. So right about here. Is it like 100%? Not necessarily. Sorry. So it's right about here. So again, that's kind of where I want to be. I want to see, do I have light field there? Mm-hmm. Let's see how much. Yep, that's good. This is an LPO, but I'm going to use my left marker on the table. Make sure I mark the left side. Is it in the light? It should be in the lower corner. Let's see. Let's see it. Just put it under his shirt. It should be fine. And this is good. The stomach is going to move up here. Remember, where's the barium in this? In the fundus. Good. So it's going to make the stomach kind of swing out this way. So you want to be focused on this side. Plus it's going to push it up under the diaphragm a little bit on hyperstenic patients. So for them, how are you going to center? You're going to adjust a little bit? Good. A little bit up. 1 to 2 inches, depending on your patient. Okay? And the barium's heavy. Okay, Mitchell. Taking a breath. Blow it all the way out and hold it out. Don't breathe and click. And you can breathe. Remember with your directions, especially these, you want to watch your patient. You know, are they doing what you're instructing them to do? So just don't say it and then take it. Actually watch your patients, follow the direction. If they're not following, stop and start over again. Say, okay, I'd like you to do this again, just so that they know they need to, and you can watch them. Okay, so I know when you're nervous, you might go fast, or you might not be thinking, or it's just, you need to always watch your patient. So those are 3 films, the most common after films for GI that you might get an opportunity to do. Some radiologists, if you have a GI that is on a patient and you ask, they still can do this, right, Janet? And you ask them if you could do the after films as your comp, they will let you. okay, especially probably places like Goodall and Southern Maine, if they're nice. The radiologists are nice. But, yeah, they might say okay. And if not, then I believe they do the whole floor procedure. You have to set up, have the correct contrast, assist during the procedure, do all of that, release your patient. You have to do the whole thing from beginning to end, correct instructions, the correct questions you need to ask your patient, and then you can do the films with Janet, or myself, or Seth, actually. We can.
Or even sometimes with the instructor at the site.
Right.
In a simulated fashion, or it might even just be verbal.
Yep.
Whatever they need to assure that you could take those images if
Right,
needed.
you could simulate it, and then look at a set of films and do the radiographic anatomy part. So if you can get it done in the site, at the sites, it's the best way to do it. Okay? Any questions? Any questions about the intro? Remember, it's abbreviated, we're not doing a full intro, but I want you to ask whether the, NPO after midnight, anything to eat or drink, repeat it. Ask about gum, cigarettes, medication, did they take any medication this morning? And there will be other things with history that you'll have to ask, but we won't do that in lab. So if you're gonna comp on this, you have to know all of those too. You might have to ask questions about their medical history in more detail about their symptoms. So, and you have to explain the procedure in a general, clear-cut way to the patient. That's what you're gonna have to do here. Sorry, Mitchell. Okay?